This conference will now be recorded.
Okay, so welcome to the class, all of you. So first I'll be just giving you a brief of this preterm labor and PROM. Then we'll do guideline, both of these guidelines. Then there will be questions, okay? And I would require one volunteer. Anyone can volunteer to when we do guidelines, okay? Now, why this preterm is important, because considerable amount of morbidity and mortality is there, okay? And what is important from this slide for you guys to remember is that yeah, at 23 weeks, if a baby is getting delivered, then the like chances of survival are very less, and it will be like 74%. No, it will be like 8%. So if baby is born at 23 weeks of gestation, so survival chance is only 8%. Sometimes this percentage is asked in the exam for part 2 and part 3. People also sometimes when this they are counseling about the very early gestation patient, then they have to tell them the chances of survival. Now it increases to 74 at 28 weeks of gestation. Then there is improvement at least 3% per day at such gestations. Okay, and if a similar improvement occur with per 100 grams increase in baby weight. Fine. So this kind of effect improvement in survival, this effects lost at 32 weeks gestation. Okay, so now the important thing to understand that why we want to increase the duration of pregnancy is only one thing. We need to increase the survival of baby and to decrease the morbidity and mortality of preterm. Okay, so what question that come from this slide is you guys have to remember these two number. Chances of survival at 23 weeks is 8%. Chances of survival at 28 weeks is 74%. These two numbers important for part 2 and 3 both people. Only this much is required from here. Now etiology of preterm labor is multiple. Okay, it could be uterine distension, ischemia, infection, endocrine disorders, um, autoimmune reaction, cervical causes, and allergic phenomena. No need to remember all this. Why? What important thing that you have to remember is that infection, alone infection, counts for 20 to 40% in cases of preterm labor. So just remember this number. That's all for it. Only this number is important for both 2 and 3 people to remember from here. Okay, because they never ask this question like what are the etiology of preterm labor. Only this percentage is important because for part 2 people it can be asked a direct question, and part 3 people sometimes this kind of scenario may be there. Then this is real important, and you will get questions from this slide. Like whenever the patient is coming to you and you are suspecting preterm labor, so you will take some history. So what history is important, and this is important for part 3 people mostly because they have to take history from the role player. Previous preterm labor, previous preterm pre-labor rupture of membranes, previous mid-trimester pregnancy loss, congenital uterine anomalies, multiple pregnancy, any bleeding, vaginal bleeding pointing towards abruption or previa, short cervix, previous multiple leads of cervix or cone biopsy. So this is real important. These are the risk factor. So whenever you are doing history for your patient of preterm labor, you have to ask all these questions. And what gets important for part 2 people is like this question I have seen in the exam that if the one preterm is there, then the subsequent chances percentages nearing 20%. For 2 preterm it is nearing 40%, and if there are 3 preterm, then the possibility of having preterm upcoming pregnancy will be 67%. These percentages are from strategy, and you need to remember, like you can remember this is 20, 40, and 60. If a woman has one preterm, 2 preterm and 3 preterm. So what will be the chances of having preterm in subsequent pregnancy? You will get this question in the exam. They will give you certain factors and they will ask you which is the most important factor that will predict preterm in the upcoming pregnancy. Answer will be previous preterm labor. Okay, this question has come in the exam. Then sometime they will give you certain factors, and after giving certain factors they will ask you like which are the factor responsible for preterm, or sometime they ask this type of question, all of these are responsible for preterm except. Okay, this kind of questions come. So you have to know this table is from OGRM general. So you have to know this table. These are the risk factor for preterm that will help in answering your question. So race, low BMI, okay, low BMI, younger age women less than 18 or more than 40, both extremes of age, poor nutrition, smoking, low socioeconomic status. So these are the maternal characteristics for spontaneous preterm labor. What could be pregnancy related problems? Multiple pregnancy, you already know it will cause overdistension. Bleed infection, we have just read it is responsible for 20 to 40% cases of preterm. Bleeding, okay, because whenever there is a bleeding there is a release of inflammatory markers, and that will bring labor near. Okay, then obstetric, so this will be pregnancy related issues where the preterm will be common. Another will be obstetric history, like any trauma to cervix, conization or LEDs, and this part we have done right now also. According to this general, like after one preterm, it will be 13%, and after two preterm, it will be 42%. Okay, but better to remember strategy numbers, that is 20, 40, and 67 for preterm number 1, 2, and 3. Then previous preterm miscarriage, previous history of repeated top. Okay, so repeated top is also a reason for preterm. So this risk factor is important to remember, because for part 2 people they will get direct question from this table, and for part 3 people they have to just correlate what are the risk factor are there in this particular patient for preterm. Preterm is again a very hot topic, because part 2 people will get question and part 3 people will get station. Now few things some concept has to be required to clear. So what is cervical length and what is funneling? Okay, why it is important? Because in the guideline these terminologies are used. Now just in basic knowledge, so cervical length is measured from in between internal os and external os. So this is the cervical length. Okay, now see this picture, and this is the funneling. Okay, so now when the cervix started opening up, so this is the funneling. So you will find in the guideline that funneling is not an indication for any kind of treatment. Okay, what they will miss the marker, what they take for the diagnosis of preterm labor or for any kind of cerclage, they take is the cervical length. Now you can see here this, so they are not measuring cervical with this funneling thing here. What they are measuring is this cervical length. Now this is the internal os for in case in this particular, this is the herniation of the fetal membrane. Okay, and this is the internal os and this is the external os. Now you can see uh, how much is the cervical length. Maybe if I am able to measure it, it will be 1 centimeter. Okay, so this is the meaning of funneling. Just you have to clear your concept. Nobody is asking this question to you. Now again, what they are measuring is fetal fibronectin. But why they are measuring this fetal fibronectin, and what is this fetal fibronectin? uh, you may get this question in the exam. Okay, and part 3 people have to remember like which are the conditions. They will not say that fetal fibronectin can be measured. Okay, so it is a glycoprotein that is present in the cervicovaginal secretions, and it is so when and it is present around 21 weeks of gestation before fusion of membranes occur. But anytime, what happens if there is any a disruption of this choriodecidual surface? Okay, pleasant. Whenever this any kind of activity or disruption is going on in this interface after 21 weeks of pregnancy, then there will be because of inflammation or because of trauma, because of this disruption of this interface, there will be release of FFN into the cervical cervix and vagina. Based on this mechanism, swab will be taken from the posterior fornix or ectocervix. Then it will be able to predict preterm labor in between 22 to 34 weeks of pregnancy. Okay, so this is the basic mechanism of this. Maybe because it is important to understand why we are measuring this fetal fibronectin. Now there are certain contraindication. So if it is less than 24 weeks, you will not measure, because by that time, as the fusion of membrane is already taking place, so it will be already present. So it will not be giving you good idea of preterm labor. So if so you can measure it in between 22 to 34 weeks of gestation. So contraindication, if the gestation is less than 24 weeks or more than 34 weeks, doing for fetal fibronectin makes no sense. Now you will when we will do a nice guideline for preterm, now you will find when the patient is more than 30 weeks, that time they are measuring fetal fibronectin. Now this will give you a correlation that after 30 weeks we are measuring it to find out the probability of preterm labor. Okay. Now, suspected preterm PPROM, if the rupture of membrane is there, so this protein, glycoprotein, we are not able to find, able to detect it from the swab, or it will give wrong result. And multiple pregnancy, cervical dilatation is more than 3 centimeter. There is no use for doing fetal fibronectin because patient is already in labor. Active vaginal bleeding, again there will be disruption of the chemistry and it will not give good result. If any vaginal examination or intercourse had happened in last 24 hours, because this will already cause some disruption in the choriodecidual interface, so there will be false result. And if lubricant gel has been used, okay, so these are contraindication for testing. This you should know, because like this may be asked in the exam, and this contraindication is from strategy. Now nifedipine, you will find nifedipine in the guideline as a treatment of choice. What is nifedipine? It is calcium antagonist. This question can be asked in the exam. This is calcium antagonist. On the other side, this is not licensed to use as a tocolytic. In UK, there are some drugs that are licensed, and but another set of drugs is also used, but these are not licensed. So there are two kind of drugs. So now you people can remember. So nifedipine, if you see guideline, that is the first choice they are giving. But on the other side, you have to understand it is not licensed to be used as a tocolytic drug. Then it is the only tocolytic drug where reports of neonatal benefits are less. Okay, neonatal benefits, there are less, it causes less, it is beneficial for the neonate, so it causes less respiratory distress, less necrotizing enterocolitis, and there is less risk of IVH or intraventricular hemorrhage. So this is the only tocolytic drug where reports of benefit like that will cause more benefit to the neonate, so less chances of distress enterocolitis or less chances of IVH is there. Sometime you will get question from here, and part 3 people also have to explain this to their role player. It do have side effects. Side effects are flushing, headache, palpitation, and hypotension. Okay, because all the effect of vasodilatation, all dilatation effect will come. So when the blood vessels are dilated, we feel flush, headache, palpitation, and hypotension. Okay, then this part is important, you will get question. It is usually avoided in the patients of cardiac disease. Therefore, from your role player, please take history of heart disease. and women with diabetes, multiple pregnancy, because we are worried. Why we are worried? Because pulmonary edema can happen. So the part 2 people will get this as a question SPA, and part 3 people, whenever they are prescribing nifedipine to their role player, be careful. You have to explain about their maternal side effects, and also you have to rule out all these conditions. So if your patient is having some cardiac disease in the your role play station, avoid nifedipine. Now atisoban. So atisoban is specific oxytocin analog. Okay, it acts on both oxytocin and vasopressin receptor. You may get this in the this as your question also. It is given by IV route only. Okay, and it is a drug that is specifically licensed for preterm labor. So you may get this question, the licensed drugs and unlicensed drug. So it is worthwhile understanding that atisoban is licensed for preterm labor. Nifedipine, though it is a first line, but it is not licensed for preterm labor. Okay, but the problem with atisoban is, first patient has to get admitted because it is given by the parenteral route. On the other side, it is very costly drug. Okay, and it has got a recommended regimen, and in previous guideline they have written this regimen, and also I have taken this regimen from strategy. I'm reading it for one time, but I have never seen question from this regimen. So usually one bolus dose is given, that is 6.75 gram over 1 minute. This will be followed by infusion, that will be 18 milligram per hour for 3 hours, then for 45 hours, and it will be continued for 45 hours, and maximum dose given is 330 milligrams. So but I have not seen any question, and you need not to explain this in the exam. Just for the sake of explaining this regime, I have put it here. You will get question from above part of the slide. Now any one of you have got asked any question till now can ask me, otherwise I'll be going for some circulage update, because there had been a guideline draft has come, but the circulage guideline is about to come. It has not come here yet. So any one of you have got asked any question till now can ask me, otherwise I'll be moving to circulage updates, because that is important to know to answer your questions. Any question till now? Any question? No question.
Dr. Priyata,
Yes.
so when we decide to use atosibam or nifedipine, do we have a preference? Matlab, if there is a question, we have to choose which one we should be choosing? Since it is atosibam is the licensed drug and the other one is the recommended drug, what to choose in the answer?
See, if you will get to know from the question. If they ask first line, if they asking you only first line drug, then you have to say nifedipine. If they are asking you licensed drug, then you have to say atisoban.
There are no contraindications for atosibam, like for the nifedipine you mentioned the heart, the cardiac thing we have to ask. For atosibam there is no contraindication.
No, it can't be possible. There would be contraindication, but I didn't put here. So,
Acha, okay.
yeah.
Okay.
So, atisoban,
Ma'am?
what are the contraindications? I'll update you. Yeah.
Excuse me, ma'am.
Okay.
What's the side
Yes.
effect of atosiban, ma'am?
Side effect of atisoban. Okay. That also right now I don't know, because I have read very less about this drug.
Okay,
So
ma'am. Okay, ma'am.
contraindication of atisoban and side effects of atisoban, I will send that in the group. Okay, because I read very less about it. I thought this knowledge is enough.
And hypotension for atosiban.
Yeah, it because it is acting on vasopressin receptor. So all this hypotension, all this thing will be there. But yeah, I'll give you correct information. So I will send that in the group. Okay.
Okay.
Now circulage guideline, the draft has already been come, okay, but maybe within a few months or so you will get this guideline on their website also. So updates I have put from that guideline, circulage guideline. It is from their draft only, because sometime you will find question and answer, you see from where I should do this answer. So I have put some of the updates, but when the guideline will come, then the things will be like, it will be we'll do guideline again, what that we can say. So now if a patient has got so there are history related cerclage and ultrasound related cerclage and rescue cerclage. Now history related cerclage, so according to this guideline, if there are 3 or more preterm birth or second trimester losses, okay, then on the basis of history only, this patient will be eligible for cervical cerclage. Okay, so I'm repeating it again. This is history indicated cerclage when there are 3 or more previous preterm birth or second trimester losses, then on the basis of history only you can offer cerclage to this patient. Okay, now ultrasound indicated cerclage. So when there had been risk factor, like there had been previous preterm, there had been mid trimester loss, or something is there, okay, then in this particular situation, and these patients are usually on monitoring, then if a cervical on this ultrasonography, if the length is less than 25 mm, then ultrasound indicated cerclage is done. So in your question you will find that there will be history of either preterm labor or mid trimester loss, and right, and this pregnancy they have gone through cervical screening, and on surveillance length is less than 25. So this you can offer cerclage to this patient. So this type of cerclage is USG indicated cerclage. Okay, so like this is the say what I said, and ultrasound indicated cerclage are not recommended on the funneling. Okay, funneling they are not taking care, they are just measuring the length, and if it is less than 25 mm, then only 25 shortened to 25 mm or less, then only cerclage offered. Now usually cerclage can be done vaginally and can be done abdominally on also. And if the patient was like, if any time previously the vaginal cerclage was done for this patient, still the patient that pregnancy ended up in mid trimester loss or preterm, that means vaginal cerclage failed, then this patient would be considered for transabdominal cerclage. And transabdominal cerclage, it is usually done, can be done laparoscopically, or it can be done via an open surgery. Okay, and whether they do with the lap or whether they do with the open, there is no difference in the patient outcome. And this is transabdominal cerclage, it can be done preconception period, or it can be done early pregnancy. Okay, so this you will find this kind of questions also, like when they will give a history, vaginal cerclage has failed, so what will be the next step? So your answer will be transabdominal cerclage. Now another situation, that is difficult situation, if the patient had abdominal cerclage, okay, and miscarriage occurred, then what you will do? Then if the patient is up to 18 weeks, then evacuation through stitch can be done, because whenever they do cerclage, they usually put in cervix 8 number dilator. So they put 8 number dilator in cervix, then they tied that tape, marceline tape, usually they tied. Okay, So that I'm just that this knowledge is not from the guideline. This is practical knowledge. Okay, don't search for that on the guideline. Then in that particular situation, because cerclage is when the knot is tight, so dilator is inside. So now this will give you an idea that evacuation can be done through stitch up to 18 weeks. Okay. Now another situation, if it is more than 18 weeks and if you are not able to do like evacuation through cerclage, then you can cut stitch via the colpotomy. Okay, then this is also possible. But another situation, you're not able to do evacuation through stitch, you're not able to cut stitch by colpotomy, then only one option is left, either consideration for hysterotomy or for cesarean section. This is the same hierarchy of the like management if the patient has abdominal cerclage and there is a miscarriage, and you will find same kind of questions. Now sometime you will find that about the rescue cerclage. So rescue cerclage is done usually in the emergency. Okay, now what type of question you will find? So if the rescue cerclage is done, then it will delay birth by 4 weeks. This question you will find in the exam. And 2 by 3 or 2/3 fold reduction in the preterm birth before 34 weeks. Then now if you are doing cerclage, if you are taking patient for cerclage, so emergency cerclage, and if the dilatation is more than 4 centimeter, it is going to fail. Why? Because you will see like you won't be able to hold the lips of cervix to put stitch in. So chance, or there will be puncture whenever you are trying to do this cerclage. So there will be increased chances of failure if the dilatation is more than 4 centimeter. Okay. Now there are, all patients are not considered to be candidates for the cerclage. So there are some contraindications. Active preterm labor, that means patient has it in advanced preterm labor. There is infection, chorioamnitis, you can't do cerclage. There is bleeding, there is rupture of membrane, fetal compromise or already there, lethal fetal anomaly is there, or fetal death is there. So these are the contraindication for cerclage. Okay, you may find question from this also. Then when if the cerclage has been done, then it has to be removed also. So what is the period of gestation when the cerclage will be removed? So it is usually removed by 36 to 37 weeks of pregnancy. Ideally, the cerclage that is put vaginally, so it will be removed vaginally. And if there had been high insertion, then it will require anesthesia for removal. All other kind of cerclage, if they have put vaginally, just by holding that knot, you'll be able to cut it. But if high cerclage has been put with the bladder mobilization, then anesthesia would be required. On the other side, if a patient has got abdominal cerclage, in that particular situation, the patient has to be delivered by cesarean section, and abdominal suture will be left in situ. Now, and you will find question from this part also. Now, if the patient has cerclage and there had been PPROM is there, that means there had been rupture of membrane between 24 to 34 weeks of gestation. Then what you will do in that particular situation, you have to see the situation as a whole. If there is no maternal infection or fetal infection, then, or patient not in labor, then you can remove suture removal delay by 48 hours so that steroid can be given. Okay, but if any maternal compromise, fetal compromise, any infection is there, in that particular situation you can't delay the suture and you have to remove the suture immediately. You have to understand this, because you will find a number of questions from here as well. Even the one time part 3 station has come from this part of the guideline. Now another important thing, so whenever you are getting a patient of preterm labor, Okay, in the management, you have to say like GBS profile access. Why? Because according to this GBS guideline, uh, this GBS profile access is offered for all confirmed cases of preterm labor, irrespective of GBS colonization. So part 3 people and part 2 people has to remember this very well. In the treatment of the confirmed preterm labor, if they write GBS profile access, your answer will be yes for it. But if you are taking preterm labor patient without any rupture of membrane for cesarean section, then IAP will not be given. Okay, so this is the slide from GBS guideline, but it is about preterm labor, therefore you have to remember it here. Okay, now you have to understand the preterm labor pathway. So if the patient is suspected in preterm labor, so like if it is an advanced you will discuss the mode of birth, you will give her tocolysis and steroid, but like this will be tocolysis and steroid will be the treatment when the patient is in early preterm labor. But if the patient is in advanced labor, then you have to give her magnesium sulfate, you have to give her intrapartum antibiotics that I just discussed, and what will be the management you will do for fetal monitoring. Okay, so this you know this is just in sum up. Now this slide will answer your all of maximum questions of preterm labor. Many times you will get question, how will you diagnose it? Now just imagine a patient and situation. So if you have to diagnose preterm, first you will take history, then you will do per speculum examination, and before any other examination, if your facility is there, then you can take FFN also. So you will get question from this line. Many times they ask you how to diagnose. So first will be history, second will be PS or per speculum examination. Second, now whenever you get a patient, either part 2 people or part 3 people, just see the gestation. If the gestation is less than 30, then please treat this woman. You have to do treatment. And what is the treatment? We have got only 2 treatment. If the patient in early labor, steroid and tocolytic. Don't forget it, steroid and tocolytic. On the other side, if the patient in your station or in your part 2 question, she is more than 30 weeks, then what you will do? Then you have to do 2 things. Either you can do TVS if the facility is there, or if the facility for TVS is not there, then you will arrange for FFN. Okay, now but you will not do 2 things together. It is only one modality you have to use to diagnose preterm. Fine. Then if the cervical length is more than 15 mm or FFN is less than 50, then patient has got no preterm labor. Just counsel the patient, give her some advice, and you can send this patient home. On the other side, your cervical length is less than 15 and FFN is more than 50 nanogram per ml, whatever the number is, then this patient is in a preterm labor. Please do the treatment of the patient. Okay, and what is the treatment? Early preterm, steroid and tocolytic. Advanced preterm or established labor, magnesium and GBS prophylaxis or magnesium sulfate or antibiotics. So these are the usually like questions you will get. And many of the time I have seen part 3 candidate, preterm labor is so simple thing, they are confused here. Okay, sometimes they usually keep on mess up at this situation. So all of you, 2 people or 3 people, just remember, if this patient is in an early preterm labor, your treatment is only 2 treatments, steroid and tocolytic. If your patient is more than 4 centimeter or patient is in an established preterm labor, change your treatment to magnesium sulfate and GBS prophylaxis. So this is the complete summary of preterm that will answer your maximum questions of preterm. So any one of you have got any question can ask me before I move ahead.
Excuse me,
Hello,
ma'am.
Dr. Priyata Lal. Hi.
Yes.
Can I ask one
Hello.
question, please?
Yeah. What do you
I-
want to
I-
ask?
Yeah, if patient is bleeding, so can we, if it is preterm and bleeding, so we can give the tocolysis, we cannot give, isn't it?
Okay, if see, Salma, there is no hard and fast rule for anything. So if your patient is bleeding, that means your patient would require delivery. Okay, bleeding patient, we cannot prolong her labor. You have to deliver her. Okay, so in that situation, you can't wait for steroid. But if you go through steroid guideline, even they say if the patient still have given one dose of steroid and she is delivered less than 24 hour, still she will get some benefit, so give it.
Mm-hmm.
Is it clear?
Yeah, but if it is mild bleeding or moderate bleeding or severe bleeding, according to this, is there any contraindication that if it is bleeding, we cannot give the tocolysis?
No. See, uh, that in the guideline also, if you go to that abruption guideline, they
Mm-hmm.
always that like abruption guideline, they always say like you have to take individualize the situation, or you have to take senior opinion. Blindly for all patients you can't give tocolytic, because if she's an abruption patient it will increase.
Yeah.
Okay, so it
Excuse me, ma'am.
can't be given. Only you have to individualize the case or assess patient as a whole, or take senior colleague opinion.
Mm-hmm. Okay,
Yes,
thank
any
you.
other? Okay.
Yeah, ma'am.
Ma'am, ma'am,
Excuse me.
for cerclage, you mentioned that active labor we cannot put the cerclage, means it is if it is more than 4 centimeter. But if the patient is in early labor also, isn't pain a contraindication for cervical cerclage? Means if the patient is already in pain, she is in preterm labor, then there is no role of cerclage in it.
See here, contraindication, active preterm labor.
If it is not active, means when we are talking about 4 centimeter means active preterm labor.
No. See, just no. Preterm labor is patient is having active pains. That is active labor. And established labor is more than 4 centimeter, and early labor when the patient is less than 4 centimeter. Active means contractions are coming.
Yes,
Is
if
it
the contractions are present, we cannot put a cerclage.
Yeah, how you will put? You will put cerclage, and with the contraction, this it will erode. It will erode.
Yes, ma'am.
Okay, can't put. And I have seen one patient in like in my clinical practice. So one of the colleague, she has put cerclage, and patient was having active pain. Okay, and that patient within a week she had a rupture of membrane, and she was taken for theater, and her tape was cut. Then she delivered that baby at like 24 weeks. So like active preterm labor is contraindication from this guideline also.
Okay. Okay, ma'am.
Ma'am.
Thank you.
Excuse me, ma'am. Can you hear
Yes.
me? Hello.
Yeah,
Yeah,
yeah.
ma'am. Ma'am, in the risk factors, as you said, you ultrasound indicated cerclage. So in risk factor, these cone biopsy leads, they will also come, or
No,
it
if
is
the
only
risk
preterm?
factor, okay, no. History means history of preterm labor or mid trimester cerclage.
Okay.
Okay, yeah.
Yeah, that doesn't mean that leads and cone biopsy, it will not come.
No.
Okay,
No.
fine. Thank you.
Okay. So now some brief.
Hi, Dr. Priyata.
Excuse me, ma'am.
I
Yes.
Excuse
want,
me, ma'am. I had a question, ma'am, if you don't mind. Ma'am, when you said that we can put either before pregnancy or in early pregnancy, so what I understand is, just wanted to confirm, in history indicated encerclage, we should ideally put it before pregnancy, right?
No. Just wait. I'll repeat my answer again. If patient,
Yes,
if
ma'am.
like patient has, you have put vaginal cerclage to one patient, okay, and in one pregnancy usually you will put vaginal cerclage. Now that pregnancy ended up in mid trimester loss or in preterm labor. That means vaginal cerclage, what you put has failed. So when this patient comes to you, then you can offer her two options: transabdominal cerclage before she gets pregnant, or transabdominal cerclage when she is in early pregnancy. So transabdominal cerclage is only put when there is a failure of vaginal cerclage. Is it clear now?
Yes, ma'am. There was a question in which both these options were there. So I was just trying to understand that definitely pre-pregnancy will be a better option rather than operating during pregnancy if we have to put a transabdominal.
Yeah.
Okay, thank you.
Okay. So
Hi, Dr. Priyata, excuse me.
yes.
That what you mentioned that about that if it is history indicated, then you will offer this cervical circulage, and if it is cervical length is less than 25 millimeter, then you will offer the that cervical circulage also. So according to
Mhm.
the NICE guideline, which one is preterm guideline, it's written that if it is history indicated, that means if previous history of mid-trimester loss or preterm delivery, and also if there is a cervical length by ultrasonography, transvaginal ultrasonography less than 25 millimeter. So if it is both is there, then we can offer either progesterone, vaginal progesterone, or cervical circulage. Both we can prescribe.
Okay.
But if it is only no previous history of preterm, but only the transvaginal ultrasonography cervical length less than 25 millimeter, then we can prescribe that progesterone only. But
Yes. You are
yeah, and if it is cervical length by transvaginal ultrasound less than 25 millimeter, and there is a history of preterm labor, or there is a less history of trauma, cervical trauma like LATS or cone biopsy, then we can prescribe only the cervical circulation.
yes. So
Yeah.
just Dr. Salma, you wait. All this slide is just coming. So I'll
Okay.
explain again. Okay.
Yeah.
Just
Yes.
because
Thank you.
the whole nice guideline will be doing, and that time also I'll again explaining. Now
Yeah.
this
Thank you.
like what is the circulage update was is there. This guideline is going to come. So I just wanted to give update so that people who are coming in upcoming exam, they should know it, because they otherwise they will get confused in the answer. Okay, but that also I'll be explaining. Just wait. Okay, now PPROM guideline. So what are the numbers important you can get from in the like part 2 and 3 people, both you have to know this. Like PPROM complicates 3% of the pregnancy. You may get SBA from here. Pre-prom associated with 30 to 40% of preterm birth. So these numbers you have to remember, because you will get direct question from here. Then they also do CRP. CRP has sensitivity of 68, specificity of 77. So in the diagnosis of chorioamnitis, so just see once this number, if it comes, you'll be able to answer. Otherwise, this number is not that important. But upper two number are real important. Then pre-prom summary also. So because these preterm and pre-prom question appears very confusing, so you have to have a clear summary in your mind, then the answer will be correct. So now first, when the patient comes to you, you have to do diagnosis. So what you will do, please do her per speculum examination. If the per speculum examination you are able to see amniotic fluid, your diagnosis is done. Don't do any other thing. But if you do PS and you're not able to see liker, then what you will do, you will take swabs, and usually tests are done for insulin growth factor binding protein number 1, or this placental, I mean like PAMG1. Okay, placental immunoglobulin. So that full form will come when we'll do question guideline. So so these tests will be done. Okay, so these actin pro and party shore, so these type of kits are there from where these kind of tests are done. Okay, so you have to understand this now, because you will get question from here, and these are very clear questions. Now again, two things: diagnosis has been done, what you will do. So if your patient, you have to see, if your patient is in chorioamnitis, you can't this pregnancy to go in, you have to deliver that baby. But if the pregnancy is if there is no infection to mother and baby, so you will admit that patient and you will give her erythromycin 250 milligram 4 times daily for 10 days. Okay, and you will find question she is allergic to erythromycin, so give her penicillin. Okay, and steroids because she is preterm. So now you see what you do, what you have to give as a treatment. You have to give as a treatment antibiotic, erythromycin, and steroid. Same patient, there is an advanced labor, so what you will do, so you will give magnesium sulfate. Okay, you will give magnesium sulfate and also you will give antibiotics. Now your patient has become perfectly fine after erythromycin. So what you will do, you can plan her delivery by 37 weeks. Okay, so this you will get this as a question. But if in your question they gave that GBS is positive, then you have to plan this delivery by 34 weeks. Okay, so this is the complete summary, and with this you will be able, you have an idea and you will be able to answer your questions. Now one thing also you have to remember about this PPROM and GBS prophylaxis. So what they are saying, so for preterm PROM, if she is allergic to penicillin, then erythromycin. Yeah, erythromycin is a drug of choice. Drug of choice, first line is erythromycin. If she is allergic to erythromycin, then you give penicillin. But this is the, I don't know, this is the question you are asking or what? Now, if your patient is with preterm PROM, then GBS prophylaxis or IAP will be offered to this patient once a labor is confirmed, irrespective of GBS status. Okay. So now, if your patient is in preterm labor, advanced labor, or if your patient is pre-PROM going to deliver advanced labor, you have to offer IAP irrespective of a diagnosis of GBS status. Okay, this is one thing you have to remember. So always think this when you are doing your answers, and part 3 people when they give option to their role player. Then now you see it here, for those who are more than 34 weeks gestation, it may be beneficial to expedite delivery if she's a GBS known carrier. Now because of this line, in the pre-PROM guideline also they say this. So in the for the pre-PROM patient, if no problem is there, then deliver plan by 37 weeks. But if she is GBS positive, then plan of delivery will be by 34 weeks. Okay, this much I have to give you a brief. Now I'm going to guidelines. So before that, if any one of you have got any question, can ask me. I would require one volunteer.
Ma'am, if patient comes in preterm labor, we will be taking swab for GBS to confirm whether she is GBS positive or not.
No.
How will we know the status then? Then if she comes in, it comes in PROM, and we have diagnosed with our active PROM test that it is, then we would be taking high vaginal swab to rule out infection.
No. So in confirmed preterm labor and in confirmed pre-PROM, IAP that is GBS prophylaxis, it will be given irrespective of carriage. Okay, so no need to take it.
You just mentioned, ma'am, if it is GBS, if it is positive, then we have to deliver by 34 weeks, and if it is not GBS positive, we can wait till 37 and then deliver her.
Okay, so what happens sometime for any reason in the pregnancy, if the swab has been done and they know they're already GBS carrier, then the delivery has to be expedited by 34 weeks. But routinely, all patients swabs for the diagnosis of GBS is not done. Okay,
Okay, ma'am.
you read it from the GBS guideline, so you will be able to get that point. Like for anything, this patient has come in pregnancy and GBS was positive, then she has a confirmed diagnosis. And same patient, if she has a PPROM, so you have to expedite her birth by 34 weeks. Okay, so this way it goes.
Okay, ma'am.
Okay, so I would like one volunteer who can, just because I want the things to be interactive, then speaking myself.
Yeah, I can too, ma'am.
Okay, okay, good. So now a patient has come to you with a rupture of membrane. So what will be the first thing you will do to diagnose that?
Sterile speculum examination to demonstrate the lichens.
Yes. So first you will take history, then PS. Okay, you do the PS and you never find any lichen. So what test you will do from the vaginal fluid?
Yeah, from the vaginal fluid, vagina will take swabs for insulin-like growth factor binding protein 1 and PAMG1
Yes.
to guide the further management.
Okay, what do you think? Have there been, is any role of ultrasound? Should we do ultrasound for amniotic fluid?
It is unclear.
Yes. I was just searching for the full form of that. Okay, we'll get somewhere.
Ma'am, that's placental alpha microglobulin, I think.
Yes, placental alpha microglobulin. Okay, so now the patient has come and you have to see whether there is chorioamnitis or not. So what you will do?
Yeah, we'll
What are
send
the
the maternal. Yeah.
So what are the symptoms of chorioamnitis?
Yeah, there will be a tachycardia, fever, discharge, abdominal pain, and fetal movements may be reduced.
Yeah, so these are the symptoms you will think that, yeah. So these are the symptoms you will see chorioamnitis is there. Now, if you have suspected it, so you will send some test. So what will be the test you will be sending?
Yeah, those will be C-reactive protein and WBC. And for fetal heart rate, either we'll do intermittent auscultation or CTG.
Yes. So what is the C-reactive protein sensitivity?
It is 68.7%. Specificity is 77.1%.
Okay. So if the patient you are sending back in a daycare unit, so how many times in a week you will call this patient for
Once or
follow-up?
twice, once in a week or twice in a week, or depending upon the if there is any concern to the woman, we will do the safety netting.
Okay.
Yeah.
Now, what is the
Any
role of
fever or-
neonatology?
Yeah, neonatology should be informed when the diagnosis of PPROM is confirmed and
Yes,
delivery is anticipated. Yeah.
yes. So always patient of preterm and patient of PPROM, there will be always a neonatologist meeting. Why? Because they will explain them about the baby's survival rate. Okay.
Yeah.
So now the patient has got no chorioamnitis. So what treatment you will give to this patient?
Yeah, if there is no chorioamnitis, then we'll start her on erythromycin for 10 days following the diagnosis or until the woman is in established labor.
And it will be 250 milligram 4 times in a day.
250 mg QID, yes.
So if we give erythromycin or antibiotics, so the fetal infection, use of surfactant, oxygen requirement, and abnormal USG before discharge, all this thing will be reduced. But what will not be reduced? Prenatal mortality.
Perinatal mortality.
Yes. So antibiotic we are
Long-term
offering,
thing.
but it will have got no effect on perinatal mortality and health of child at 7 years of age. Okay. So why we are not giving amoxiclav?
Any
Yes.
risk of neonatal necrotizing enterocolitis.
Yes. So patient patient for pre-PROM we give two treatments. One is antibiotic, another is steroid. So now where at what time the steroids are given? So if your patient, now there is confusion here. So in between 26 to 34 weeks, you will always offer steroid, but 1 week before it or 2 weeks after it, you will consider steroid. So there is difference in between recommended, offered. That means it is definite treatment. And if they write consider, that means they may give also or they may not give also. So it is important to understand, because sometimes you will get confusing question where I should sometimes they will write recommend, sometimes they will write consider. So main is this one. Okay. So the steroids are offered in between 26 to 34 weeks of pregnancy. So 1 week before it can also be offered, but this line is different in preterm guideline. In preterm guideline, they will say consider, but whenever we have, there are two answers to a question, then recent guideline answer will be taken, and also GTG has always preferred for answer than nice. Okay, so you have, so whatever, if you have got confusion, so GTG is always has got higher grade or marks. Okay, so just remember this, it is offered between 26 to 34 weeks. 1 week before also it is offered, and after 2 weeks of this age, then it will be considered. So if you get this gestation question, answer consider. So why we are giving steroid? There is decrease in RDS and also intraventricular hemorrhage.
Yes.
So what about magnesium sulfate? When it should be given?
In advanced labor.
When the patient is already in labor, or or patient is not in labor, but you are planning her to deliver for any reason. Okay. So, but baby is going to come. Baby is going
Within
to come.
24 hours.
In that situation, you will give intravenous magnesium sulfate. And what is the gestation?
24 to 29 plus 6 weeks. 29 weeks plus 6 days.
Yeah, 24 to 30 weeks you will give. And what it does, it decreases cerebral palsy and motor dysfunction. Okay.
Okay.
This is a main important thing that you have to remember. Tocolysis is never given if the patient has pre-PROM. Many time I have seen part 3 people making this mistake. They give tocolysis in pre-PROM. So this should not be given. Please, all of you 2 and 3 people, learn this line by heart. No tocolysis for pre-PROM. So so whenever the patient is offered outpatient care, So how it will be monitored, so that plan, and when the delivery will happen, so that plan will be individualized. Okay. So what do you think, in pre-prom any in amino infusion is a treatment?
No, not recommended as part of routine clinical practice.
Yes. So post-traumatic disorders are common in the women. So how much postnatal depression can happen in pre-prom antenatal?
Yeah, it can be 14%.
And postnatal depression?
14%, 17%.
Yes. So these number, like it is 14. In antenatal depression can be 14%, postnatal depression can be 17%.
Yeah.
Okay, so whenever you plan, what is the time you will plan delivery?
For preterm labor,
No, for
yeah, who have PPROM, for PPROM, if there is no contraindication to continue the pregnancy, then expecting management till 37 weeks. And if it is GBS positive pregnancy, swaps are positive, then termination at 34 weeks is advisable.
Okay. So that's all for this guideline. Now this guideline is like confusing. So now the few confusions why it is there, and like what even Salma was saying. So now there are you think this as a 3 parts, then the answer will be clear. So now one kind of patient you will offer either progesterone or cerclage. Okay. Second group of patient you can you can offer only progesterone, and third group of patient you can only offer cerclage. Okay, just divide your patient into 3 parts as the and then your answer will be right. It is a bit confusing, though I have made a summary slide for this also that I will share. Now what is the situation? You can offer both things, either progesterone or either cervical cerclage. If the patient has a history and ultrasound is done that shows cervical length is less. So if this situation is there, okay, like history plus ultrasound scan, so she is eligible for both treatment, either and or. Okay, this is from preterm guideline. But if we go to cerclage guideline, what we read in cerclage guideline, they're only speaking about cerclage. They're not giving progesterone as a treatment. Therefore, they say cerclage. So if we take go to that guideline, so this will come under ultrasound guided cerclage. So the answer will be same from both guideline. But in this guideline, because the progesterone is also a treatment, so if you can offer both of the things. Is the thing clear now, Salma?
Yes, because I was confused when you explained, but I know this one. Yes, that's why I told
Yes.
you. Yeah.
Yeah,
Thank
and if you have got any confusion, always answer from GTG, because there are 2 things there, but it is going towards ultrasound indicated cerclage. Okay, but progesterone not given in that guideline, but it is there given here. So if you have got option prophylactic cerclage, prophylactic progesterone, or third choice prophylactic cerclage or progesterone, so your answer will become number 3, because you have to offer 2 options. Okay, so this is one type of situation. Another type of situation, you can give only progesterone. Okay, what is that situation? If one thing is there, either patient has history, or if you have done ultrasound, patient has got less cervical length. Now progesterone, you can see it is a very simple treatment. So if either on the basis of history or on the basis of ultrasound, you can offer vaginal progesterone. Is it clear? And if you are giving vaginal progesterones, you have to continue it till 34 weeks. Okay, this was updated in 2019. So vaginal progesterone treatment will be started somewhere in between 16 to 24 weeks of pregnancy, and it has to be continued till 34 weeks. Now, what are the patients you will only offer cerclage? So these are the patient where ultrasound obviously less than 15, but they have got pre-PROM in last pregnancy, or they have got cervical treatment. So these kind of patient where pre-PROM or cervical trauma plus ultrasound, this type of patient you will offer cervical prophylactic cervical cerclage, and it has to be offered between 16 to 24 weeks of pregnancy. Now, is the thing clear, or should I repeat it again? Is it clear?
Yeah, means it will be combination.
Yeah.
Like TPS will be doing, and then PPROM in past pregnancy specifically, and history of trauma like LEDs and cone biopsy.
Yes, yes. So I will repeat it again, then the things will be more clear. So we can offer either progesterone or cerclage if patient has got history and ultrasound the cervical length is less. So if is the situation, then we can say to the patient, okay, either you can take progesterone or we can offer cerclage to you. This is scenario number 1. Scenario number 2, our patient has got only history, or we did ultrasound today and her length is less. Then if only one thing is there, we can offer her only progesterone. Third situation, our patient has got a history of PPROM. Imagine it is PPROM, it is not preterm here. Patient has got pre-PROM history or cervical trauma history, or an ultrasound length is less. Then we can offer prophylactic cerclage to this woman. So there are 3 set of different scenarios and 3 set of different answers. Okay. Now the things will be clear, I think. So again, same thing. So if the patient of PPROM comes, so you will take history, and what you will do, you will do PS, and on the PS, if you are able to find fluid, that is fine. If you are not able to find, then you will take fluid test. Now here is the full form is there. So you have to check insulin like growth factor binding protein, or you have to check for placental alpha microglobulin 1. This you have to remember, just because it comes in the exam. Okay, now again, this is the same thing, you know, what we did from PPROM guideline. So erythromycin, same dose, and if the patient is like allergic to erythromycin, then oral penicillin. This part again, what we said, when the patient is coming, we have to see chorioamnitis. So we will do 3 tests: C reactive protein, WBC count, and CTG. Now come to preterm labor. Okay, now you just Jatinder, if the patient of preterm labor has come, so what you will do?
Yeah, preterm labor, first of all, history, and then assessment in the form of examination. So examination to see the cervical changes. So
Yes.
if there is any, yeah.
So when the patient is of preterm is coming, first obviously every time we'll take history, then we'll do PS. On the PS we'll look for cervical dilatation, and if nothing is clear, we can do digital vaginal examination, but if we have to take swab for fetal fibronectin, we have to take this swab before we do digital examination. Now, this is the same thing like we did. So if your patient has come less than 30 weeks with a preterm labor, what you will do?
Yeah, we will treat.
Okay, now if your patient has come and she is more than 30 weeks, what you will do?
Yeah, we'll do the TVS or the fetal fibronectin swab we'll take, depending upon patient's choice and availability.
Yes. Now, if the cervical length is more than 15 and if the FFN is less than 50, okay, negative, then she is
Yeah.
not in preterm labor. She can go back home, okay, or like you will give some advice. But if it is
Yeah.
less than if it is less than 15 mm and if the fetal fibronectin test is positive, this patient is in preterm labor, then you have to treat it, okay. Now,
Yeah.
Sophia, when we are thinking of preterm labor at 30 week of pregnancy, whether she will deliver or not, then the threshold is 15 mm. Okay, but any other time before 30 weeks, if we are doing any diagnosis of preterm, then we are taking it at 15 mm. I think your question will be clear. Okay, so we offer tocolysis. So what is the tocolysis we give?
First line is nifedipine. It is
Yes.
unlicensed. It has some certain side effects, and it has to be avoided in cardiac patients, and need to be careful in certain group of patient if woman is diabetic or there are multiple pregnancy. And
Okay.
yeah.
If
And
nifedipine
another
is
is, yeah,
yeah,
in that case, oxytocin receptor antagonist, which is atosibin. And
yeah,
beta mimetics are not to be offered.
yes. Now, treatment for preterm labor is only two, tocolytics and steroid. So steroid, what we said, it is offered 24 to 34 weeks. Okay, in PPROM guideline, they said it 30.
Ma'am, it was 24 from 30 from 24 to 34 weeks. In the guideline, it was given that it is to be offered and considered between 34 and 35 plus 6 weeks.
Okay, so in between 24 to 34, it is offered,
Offered.
and yeah, and 2 weeks later and 1 week before it is considered. Okay, so offered is, this is like definite group of offered 24 to 34 weeks.
In that guideline, this group was not there, 23 to 23 plus 6. There it was 24 to 25 plus 6 and 26 to 33 plus 6.
Yeah, in that's what I was thinking, this group was different. In pre-prom guideline, they say it is 26 to 34.
Yeah. Yeah.
Yeah,
And but above group was also offered, that 24 to 25 plus 6. So the same thing it is written here.
same thing is there. So 24 to 34 34 weeks, or so it is the same thing. So 24 to 34, both of guidelines saying offered, and like after 34 till 36 weeks, like 2 additional week you will consider. So it is just a blanket thing now. 24 to 34 you have to offer it definite treatment, and once the 34 weeks are crossed, for next 2 weeks you can just consider whether you will give or whether you will not give.
Yeah.
Okay, so when the magnesium sulfate is given?
When labor is anticipated within 24 hours.
Yeah, and it is given the 23
Advanced
to
labor.
okay, and when
Yeah.
you will consider magnesium sulfate? Consider, it is not
Yeah, 30 weeks onwards till 33 plus 6.
yes. So 24 to 30 you will offer. It is must, every patient less than 30 weeks should get magnesium sulfate. But if your patient is more than 30 weeks and less than 34, in that particular situation you can still think of it, you can consider. So what is the dose of magnesium sulfate?
The same 1 gram IV loading dose, 4 grams, sorry, IV bolus over 15 minutes, followed by IV infusion of 1 gram per hour until the birth or for 24 hours, whichever is sooner.
Yeah, and for early recording of pulse, blood pressure, respiratory rate, and the deep tendal reflexes, patellar reflex are checked. And if any sign of toxicity, then you will reduce or stop.
Okay. And oliguria also?
Yeah, renal involvement.
Yeah.
What they are saying for fetal scalp electrode? So less than
34 weeks will not put fetal scalp electrodes?
Yes, fetal blood sampling and fetal scalp electrode. Because of the prematurity thing, they don't want to use less than 34. But if the patient is 34 and 36 weeks, then they will discuss it with the family members. Okay. Same thing is for fetal scalp electrode, and same thing is the fetal blood sampling in the preterm labor. Yeah. And mode of birth, it could be either vaginal or it could be cesarean section. But if you are taking this patient for cesarean section, then there is a possibility of vertical or incision, because lower uterine segment is not formed in preterm labor. So this will have implication of future pregnancy, of placental complication and rupture. Okay, so this also, whenever you are doing role play station, and if you find that you are you use more, many of the time they will give preterm, and that preterm will be with breech, so you have to explain about the vertical incision.
Vertical incision. Okay.
And if the breech is there, 26 to 37 weeks of pregnancy, they say consider cesarean section.
Cesarean section. Okay.
Now, if the baby is born, so they what they are saying, consider milking of cord, or like if the baby is required to be for resuscitation to be taken immediately, then milking of cord can be done, and cord could be clamped as early as possible. But if the baby is not in distress, then you can wait for 30 seconds, but you have to cut the cord before 3 minutes. So this you will get question from there also. And baby should be kept at a below position of placenta. Okay, so these are few updates. Sometimes you will get question, what is diagnosed preterm labor?
Diagnosed preterm labor.
So diagnosed preterm labor,
Sorry?
when the patient has suspicion of preterm labor and you have done test and that has come positive, so that it is diagnosed preterm labor. Okay, and established preterm labor, when the patient is having progressive having contractions and also progressive dilatation from 4 centimeters, so it is established preterm labor. Then pre-PROM, when the rupture of membrane occurs before 37 weeks of pregnancy and patient is not in labor. These are the definition you should know. What is suspected preterm labor? When you have got suspicion of preterm labor, but on the clinical assessment, but no test has been done. Okay, that's all for this.
Okay.
So any one of you have got any question can ask me. Otherwise, I'll be giving you questions.
No, ma'am. Thank you, ma'am.
Okay, now you start questions. So what will be the question answer?
It will be B.
It will
Admit
be
to the ward. B, ma'am, B. Antenatal ward, prescribe erythromycin 4 times a day under course of steroid.
yes. So now this patient is in PROM, but there is no contraction, nothing is there. So there is pooling there. So this patient has got no choraminitis. So what you have, so this is pre-PROM. So you have to give treatment. So treatment will be antibiotic plus steroid. Okay. So answer will be admission, antibiotic and steroid.
I think same question.
Yeah, but they have given doses.
Okay,
Yes,
doses. And again, it is B, ma'am.
yeah, again it is B.
It will be IV atosiban and commence a course of steroids.
Yeah, so the patient, she is having painful contractions. So she is in preterm labor, okay? So you have to give her a steroid and also you have to give her tocolytic. So only one is, C is the answer. So treatment for preterm, steroid and tocolytic. So patient is in advanced labor. In advanced labor, we give magnesium sulfate
Maxel.
or we
Max.
previous prophylaxis. So Maxel will be the answer.
B, ma'am. Start broad spectrum antibiotics, perform a cesarean section, and deliver the fetus the plans for ex utero transfer.
Excellent. So broad spectrum antibiotic, choraminitis. So broad spectrum antibiotic, poor Bishop score. You can't continue the labor. So cesarean section. And as the level 1 unit is there, so you have to send this baby. So cesarean section, broad spectrum antibiotic, cesarean section, and deliver the baby for ex utero transfer.
Excuse me, Dr. Priyata Lal.
Yes.
Not this slide, previous slide. Can you see that there is a bleeding, but she received that tocolysis? Not
Which
this one,
slide?
the previous one, previous one.
Maxel.
Yeah, light bleeding, 29 weeks, but
So light
she
bleeding.
received,
See, if it has been spotting, then steroid will be given.
But not tocolysis, isn't it? Only the steroid. Steroid you
Yes.
can give, but not
Is
tocolysis.
Salma, like if you are taking this patient for delivery after like 12 hours also, then also we give steroid.
No, I'm not talking about the steroid, tocolysis. That if it is bleeding, we cannot give.
Tocolysis you will not give.
Yeah, this is the one. Thank you.
Amen.
She okay, she presents as postnatal visit. Okay, they have given answer as elective cerclage, but it should be a transabdominal cerclage inserted preconceptionally.
Dr. Priyata, in the last question, when you said the transabdominal can be used, but it depends upon the time we put the cerclage also. The management does matter. Like if the patient I have seen and we put a cerclage at 24 weeks and then she delivers at 30, then next time if she comes, I will put it just after her first NT scan, and that would possibly improve the prognosis in this pregnancy.
Yes.
Yes, it will be C only.
No, it cannot be
Ma'am,
vaginal.
ma'am,
It has
because it is not a failed cerclage, because it was put at 24 weeks and she delivered at 31 weeks. So it is a successful cerclage.
It was put when the cervix was already very small. It was like one millimeter, and
10,
Marcelin tape 10 mm.
1 centimeter.
Marcelin tape our is 3 to 5 mm. So मतलब कैसे लगाया हुआ उन्होंने with a very
yeah, it
small.
will be difficult.
It is
Okay.
likely to fail. But if I put it on a bigger cervix, it can be a little better. It can work little better if I put at 12 weeks.
Okay, so what is the theme of question? So cervix is small or there is a failure of cervical cerclage. So this patient is a patient for transabdominal. Now the thing is that whether it has to be done preconceptionally or whether it has to be done like at okay, they are taking it as a transvaginal cerclage only.
Yeah.
They're not taking it as a failure. They're not taking this as a failure.
Yes, because from 21 weeks till 32 weeks, it has been stretched from 24 weeks.
Yes, she delivered at 32 weeks.
And guideline also says that if we put a cerclage, it can prolong the labor for 4 weeks. If it is 4 weeks plus, means it
Yeah,
is
yeah,
successful.
it is successful. Therefore, they are saying cervical cerclage, but it has to be done early. So it is a cervical cerclage, but it is earlier than this age. Okay, yeah.
Because now it is 3 preterm labors. So criteria she fits into.
So twin pregnancy and all the symptoms of pulmonary edema.
Nifedipine.
It
Nifedipine.
has to be nifedipine.
Ma'am, give betamethasone and erythrocin and remove the cerclage after 48 hours, ma'am.
But erythromycin we give before 34 weeks. She's past 34 weeks.
Oh,
We have to do something for her. Like she can.
give betamethasone and atosiban and remove the cerclage after 48 hours, ma'am.
Ma'am,
It
but
is
circlage
PPROM.
was put in this pregnancy. It is nowhere mentioned that there is an encirclage in this pregnancy.
Yeah, this is
It was in past pregnancy.
it was in the past pregnancy, but like they want us to assume that it is already there. See, the betamethasone atosiban you will not give because PROM is there.
PPROM.
Yeah, it is there, you will not give. And 34 weeks already passed, she's 35 weeks, even erythromycin you will not consider. So these two options are already over. Category you will not do cesarean for this woman. She has a history of normal delivery. So you are left out with last option. So this answer will come by excision, by
Ma'am, but why before
exclusion.
37 weeks induction in this case? We usually
Why?
wait till 37 weeks. There are no signs of infection, so there is no
Yes, you're right.
indication for
Okay, so
induction right now. We can wait till
I'll give
37
answer.
weeks.
I will just so this answer previous guideline. So this pre-prom guideline is updated, and in June, last June, it has come. But the pre-prom guideline before, when it was there, that time it was 34 weeks. Every pre-prom patient has to be delivered. Okay, and this question and answer is from answer corresponding to that guideline. Therefore, they are saying it remove suture and consider for induction. Like after 34 weeks, they have to deliver according to previous guideline. Okay, so now you have to change the answer according to new guideline. But if you think of new guideline also, then also atisoban you will not give, cesarean you will not do, and either you can do this from new guideline, betamethasone you can give and remove surplus for after 48 hours because there is no infection, or you can do this. Okay, so if we consider new guideline as a standard, then answer will be B. But according they have answered according to old guideline, when by 34 weeks they have to deliver PPROM, therefore the answer is this. Is it clear?
Ma'am, yes, ma'am, this is clear, ma'am. I have a doubt. Between 34 to 37 weeks, we can't give erythromycin for pre-prom?
No, it is never mentioned like that. Any pre-prom you can give it for 10 days.
Right, ma'am. So according to new guidelines, then second is okay in all ways, no?
Yes, according to new guidelines, second is okay, but it is from the previous guidelines, so they have to deliver it by 34 weeks. And she is past 34 weeks, so they want to deliver her. Therefore, last option five, fifth is an answer.
Okay, ma'am. Thank you.
These are strategy question, you know. So I cannot change nothing.
Cesarean section, lower segment cesarean section.
Yes, because footling presentation, you can't do anything cesarean section.
Ma'am, it has to be betamethasone and oral nifedipine. No, they have not mentioned about active contractions or established labor, so we don't know for sure whether to give naxalfin or not.
Yes. So answer C, nifedipine and betamethasone.
But
Ma'am, options, please.
oral erythromycin and betamethasone. M.
Yes.
Ma'am, question, can you see? Options. N, ma'am.
Why N? Why? So what is more important?
Okay.
Betamethasone or nifedipine?
Betamethasone is more important.
Yes. So answer will
Betamethasone.
yes. Steroids.
Yes. Question.
What is the answer?
Ma'am, question. Cesarean section.
Yes.
Regular
Transfer.
uterine.
B, ma'am.
Transfer.
Cesarean section, ma'am.
Yes. Transverse position. Only option left is cesarean section. So transverse position is keyword here.
Ma'am, here I have a doubt. Anytime between 24 to 28 weeks, if there is a transverse lyle, they'll take for cesarean. Like if it is 25 weeks, 26 weeks.
Transverse has to be cesarean. 29 weeks
What I mean
transverse.
to say is if it is like 24, 25 weeks also, even then.
Then I think no, they will discuss it. They may wait for normal labor because sometime baby turn.
Yes, sir. Okay.
Ma'am, cesarean section, ma'am. It seems as if it's abruption. B.
APH.
B, ma'am.
Yes. Yeah, so this is abruption. Tense uterus and vaginal bleeding, these are key words. Tense uterus only happens in abruption. And uneffaced cervix, that means low Bishop score, can't deliver, can't wait, cesarean section. Yeah, it is very easy thing.
29 plus 6.
A, it's offered, so 29 plus 6.
The
So Preterm,
transvaginal ultrasound.
Pretest from cervix appear low.
It's E, transvaginal ultrasound.
yes, transvaginal ultrasound.
E.
Yeah, E.
Betamethasone, B option.
Yes, B option.
Ma'am, but actually in previous question I had that doubt of the last option also, where it was written oral dexamethasone with tocolysis.
Or dexamethasone is not given oral, it is IM only.
Sorry, right. Yeah.
You know, with this is just a play of words.
True, so true.
Is it E, ma'am? Start antibiotics.
Yes, because now she is having chorioamnitis. So chorioamnitis, you can't do expectant, you can't do cerclage, you can't rupture membrane, you can't do amniocentesis, start antibiotics.
Nifedipine, ma'am. There's no contraindication, so nifedipine. Because the
Actually,
question they have specifically mentioned you decide to start tocolysis, so they have not asked for other things.
but they have
Why not etoposide?
book has given answer as atisoban, but I will also consider for nifedipine. Why? Because they are transferring her, so they can't give IV, they have to give oral. Okay, so I will go for nifedipine. Book
Ma'am,
answer
if
is
this transfer thing was not there, and if they ask the tocolytic of first choice, even then we'll take nifedipine, no, even though it is not having that approval.
that also nifedipine.
Nifedipine, ma'am.
Any sign of hypotension is there?
E. Ma'am,
Yes.
it was E right.
No, it is retrodrain. So
Oh,
palpitation, chest pain, shortness of breath. Nifid, it will be retrodrain. Now, with the
okay, ma'am.
Nifid, they will say headache, flushing,
Ah,
or fainting, hypotension. They will give symptoms of hypotension. Okay, so tachycardia is characteristic of beta mimetic. So it is retrodrain.
Speculum.
Yeah, it is straightforward. So what is the treatment for PROM?
Antibiotic and steroid.
Yes.
Weekly full blood count. C-reactivity. No. Ma'am, is it C?
A, ma'am.
So it will be antibiotic and steroid. Right, this is the subsequent management right now. Then they will assess and how they will follow this patient. That part has
Okay.
not decided. That treatment is decided by the individualized person. So answer will be antibiotic and steroid because it is the only answer from the guideline. Ultrasound is not done to confirm diagnosis. Sophia, we just read from the guideline. Role of ultrasound in the diagnosis of pre-PROM is not clear. This is from the GVS guideline, I think it has come.
Induction of labor
Yeah, induction of labor
plus
and
benzyl penicillin in active labor. D.
yeah, D. It is very famous question. It keeps on coming always.
C, ma'am.
So this is question. Okay. And this is option.
Ma'am, question, please. Okay. Options, ma'am.
So she has ultrasound and a
V.
history. V. So ultrasound and history. Two things
so
are
V,
there.
V, ma'am.
V will be the option.
This
Yeah.
was that
Progesterone or circulage.
class.
So this is that now you can see if there is history and this TVS. So this is option. This is from this. So you can offer either. Now she has got only scan.
Progesterone.
Vaginal progesterone, ma'am. You.
Yes. So only so either history or ultrasound progesterone. So this will go to number 2, history or no, ultrasound. So you can give only progesterone. Now she has got LEDs and ultrasound.
Circlage.
Yeah, so it will be
Prophylactic Q.
circlage. Now the things are clear. Though this
Yeah.
guideline becomes so difficult. Again,
Yes, ma'am.
the question is from here. So ultrasound and either PPROM or trauma, answer will be prophylactic circlage. So patient has PPROM and no problem. So what you will do?
Antibiotic
Ma'am.
and steroid.
C, ma'am. Antibiotics and corticosteroids. C.
C.
C, antibiotic and steroids. Look for better answer.
It will be H.
It will be H. So the here happens mistake, people. You will think you have done very good, but H is also there. So answer is erythromycin for
H,
tendon.
yes, yes, ma'am.
Yeah, so you have to read all options very well. Now she's PPROM. Not contracting. What is next step? What you will do next? Brought by ambulance.
Examination. Speculum examination. J.
Now she is in suspected preterm. What you will do?
Biotics.
30 plus weeks, 30 weeks suspected preterm.
Okay. TVS.
TVS. Yes, very good. TVS.
Yeah, answer.
You
FFN.
don't have,
Swab.
yes,
Fetal
FFN.
fibronectin.
Swab. H.
Fetal fibronectin. Where they have given it? This is
H.
oncofetal. Yes.
Oncofetal fibronectin.
Yes. Yeah, that's all. So any one of you have got any question can ask me. Any question?
Thank you so much, ma'am.
Okay, welcome.